Hello and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am so excited to have with me Dr. Bex Eliot Canner, who is a family medicine physician by training, but is currently transitioning into a non clinical role and is one of the founding members of Pride in Health Charitable Trust and lives in New Zealand. Welcome. How are you today?
Good, thank you, Mary. Really excited that you have me on this podcast. A little bit nervous, but I'm sure you'll put me at ease.
Yes, well, don't be nervous. I'm excited to learn about your career that kind of spans from rural America over to rural New Zealand. And I'm excited about learning a little bit about the new things that are on the horizon for you. Um, but generally, I usually like to just start and kind of find out your journey to medicine. So, family medicine, which took you to rural Maine and then rural Montana. So, tell us a little bit about why medicine, why family medicine, and then how you ended up in those places.
Okay. So I started off at McGill University in Montreal, and I ended up at some point doing a um, rotation in Bangor, Maine, family medicine. And I was one of those people that I just couldn't pick one thing, so family medicine was kind of the, and I loved Maine, and I liked the more rural sort of setting. I was getting, Montreal's a lovely city. I love it, but starting to get just a bit too city-ish for me. Um, like loud and, I don't know, busy and stuff. Um, and so I ended up applying to more sort of more rural residencies mostly, and applied to all the residencies in Maine. There's four family medicine residencies, and matched with Lewiston. And yeah, they have they have more of a rural focus, where I actually ended up doing more. So it's a community hospital that's not terribly urban, but going to like Moosehead Lake and Bridgeton, these places outside of Lewiston that were quite a bit more rural. And I really loved the challenge of it. Like, you really do a lot.
Yeah.
And that was my thing. I think that made me want to kind of continue in that track. Uh, there, yeah. So I ended up in Montana, as I told you before we started, because of a relationship. I never wanted to leave the coast. That's the things you do for when you're in love or infatuation or whatever. Um,
Life takes us
and
places.
and Montana is, they call it frontier because the population is so sparse. It's
Mm-hmm.
not even rural. And I think that I found out later when I got more involved politically it's kind of a political funding sort of designation. But I yeah, again, I like the challenge of it. I don't think I'm as suited to this lack of diversity in rural places as I am to more urban places. So I kind of done some,
Flip flopping.
um, yeah. And at some point, I got really quite burned out on the U.S. healthcare system. I probably a bit burnt out on family medicine in some ways. I'm kind of an introvert in a way. I'm a talkative introvert, but talking to people all day long just is really exhausting. And my relationship was kind of
Evolving.
tanking, I guess you would say. um, so yeah, we decided to come to New Zealand, to have like a little, I'd say maybe push the reset button a bit. But I got this job, and I was sort of rooted into this job in rural New Zealand because of my rural experience and my interest in teaching. And it was a rural immersion program for fifth year medical students. They have a 6 year program. It's a bachelor's program. Fifth years, the first sort of primarily clinical
Mhm.
year. And these students were picked from their class to go to one of six rural sites for their whole year to do the whole try. And it's a big year for them. They have a huge set of exams that sort of charts their future at the end of the fifth year. So I was responsible for making sure they got all requirements in kind of an integrated community health kind of setting. Once again, New Zealand rural communities are similar to Montana rural communities in many ways, very farming, very homogenous, very white, very sort of straight. um, and so I was a little bit different, I guess, just being gay, being gender nonconforming, being just being me. Um, and Yeah, so I did that for 7 years. My partner, we had a child that we adopted together, um, who was, I think, very much more attached to my ex. So they went back to the States, and we tried to make this work. And then COVID happened, and I actually haven't seen my child for other than on like Zoom and video for over 2 years. So now I have a new partner, and we're heading back. In the meantime, I've moved to a city in New Zealand because I just got sort of quite tired of sort of the rural, I don't know, small-minded attitudes maybe, and wanted to do more. And I ended up in a job in a youth health clinic where probably at least uh, I don't know if I would say half the patients I saw on any given day were LGBTQ plus. I started doing a lot of gender affirming healthcare, looking after transgender young people, and also in addition to that, doing a lot of locums in communities that had a lot more indigenous people, refugees, a much lower socioeconomic demographic, and really getting quite a bit more sort of awareness or interaction with people who are underserved in a different way than rural people who are also underserved in a certain way. Um, and yeah, that's that's been a break in the burnout perhaps, but because we're talking about going back to the States, I dropped my board certification for one thing, but I'm no longer interested in clinical practice in the US. That's one of the reasons I came to New Zealand in the first place. So trying to transition into something that's more with writing and advocacy and where I can use some of my transferable skills but not be seeing patients. Um, I'm not entirely sure what that's going to look like at the moment, but just
I'm sure
trusting
it's
it'll
going to
happen.
be exciting. And before we move away from rural health, because that's not what we're going to spend most of our time today, but just to give our audience a little context, since we both spent time in Maine, and I'm currently in Maine now, and thinking about population size, and you talked about Montana being the frontier. Thinking about it as a frontier, and when I went there and learning that they called it Big Sky, and I was like, that's an interesting thing to say. And then you get there and you're like, oh, I see why they call it. I mean, you can see forever. Um, and in Maine, the big city is Portland, and its population is somewhere around 65,000, and that's the big city, right? And so when you
Yeah.
talked about Lewiston, even though it has a more urban feel compared to like where I am in Norway, it's by no stretch of the imagination a big town. And so thinking about health equity from a rural standpoint, it's a different conversation because, like you said earlier, when you think about the health equity conversation, a lot of the topics are the same, but execution is slightly different, right? Because
Mm.
of how the population is spread out, the space between providers, right? Because you said there's only 4 residency programs in the whole state, so that's reflective of how much healthcare there's in the state and how far away. People have to drive and an hour and a half to come see us
Hmm.
here, and so that's a big difference between, and that's an hour and a half, not on the highway, right? These state
Yeah,
highways,
little
backwoods,
windy
and
roads.
winding around, and um, so it adds a
Which is
whole
very much
nother
how it is to travel in New Zealand too.
layer.
Very
So
similar roads. Yeah.
right, so that's a whole nother conversation. But I just did want to touch on that. Um, and so thinking about kind of your work now, and having the opportunity to work with that population. So we talk a lot about when we have vulnerable populations, and sometimes the access is not there. So we talk about availability, is a number of providers, location of providers, insurance, we go through all that, but also comfort level. And when you walk in, that somebody's going to understand your story and provide you appropriate and comprehensive care. So can you tell us a little bit about that from the LGBTQ plus community, and what those particular challenges might be? What's the importance of a clinic like the one that you're working in New Zealand?
Yeah, no, that's a really good question because that's kind of the basis of the work that I'm doing with, um, so the Pride and Health Trust, which you mentioned, six GPs, we family physicians, we just call them general practitioners in New Zealand. I know a lot of family doctors in America just get really incensed by that term, but anyway, that's another story. Um, who Five of us are LGBTQ plus, and there's one sort of token cisgender straight woman uh, who does a lot of gender affirming care, especially at the university health level, um, who have seen this gap with doctors and providers who um, are just not sort of sure how to make their practices look inviting and inclusive, and how to be inclusive. It's not just about looks, but I think of it, partly from my perspective as a patient of walking into any space and immediately kind of looking around, like, how is this going to be? And I'm sure it's probably similar for people who are, racial or ethnic minorities, or even people who are visibly disabled. How accessible is the space? All sorts
Right.
um, of the, different groups that aren't sort of in the mainstream, whatever that might be. Um, so, um, and you look at, like, the intake forms and what options do they have for gender or marital status, and coming through, coming out in the 80s and 90s, it's a bit different back then. Um, you're always assumed to be in a heterosexual relationship, and if you're a female presenting person or you're a cisgender female, what do you do for birth control? It's all just very binary and very sort of, and it feels excluding, and it doesn't feel safe to come out and it to your doctor or to your nurse, and if it doesn't feel safe for whatever reason, you're not going to get the care you need. It's just that's the simple answer, you know. And so in terms of um, in particular, in terms of transgender folks, either people who are non-binary or people who are, transitioning from male to female, female to male, or wherever they are in that spectrum. Um, I'm very aware when I go to a doctor, like, do they just have male and female on the form? You know, we have a countrywide medical record system that's very old-fashioned in terms of what the options are, and we're quite limited and have to do workarounds. And I've talked to the people at the Ministry of Health about that. Like IT systems. Are we able to have the person's name and gender correct on a prescription or a lab form so that they don't have the distress of seeing their dead name, um,
Yeah.
or things like that. Just it's very basic. I mean, I was writing the content for our website. Our website is the main work that we're doing for Pride and Health, is having a website with really robust content that people can go to, like, it's one-stop shop kind of thing, to say, how can I make my practice more LGBTQ friendly?
Right.
How do I go about talking to people about sexual health or gender affirming care? so forth. And I was writing this content and thinking, basically, it just comes down to, um, well, in my head, it's a little bit more crude, but um, just being kind and
This is
checking
a
your
family
assumptions.
friendly show. Family friendly show. No.
Yeah.
Excuse me.
um, just, yeah, be nice, be kind, and check your assumptions. Don't assume everybody's like you. Don't assume everybody has an experience like you, and just keep an open mind. And for some reason, that seems to be really hard for some people. Um, so the clinic that I don't work there anymore. I quit about a month ago, and I'm just doing locums now before as we get ready to move back overseas. But that I worked at for a little over 3 years. You walk in and there's like a big rainbow flag. We actually somebody gave us a neon sign that looks like a condom. It's quite funny, but it's and there's a it's under 25. It's a youth clinic, so it's got to be youth friendly as well. We have to sort of present the image that like you can talk about anything here. This is not one of your like crusty old man doctor, practices where nobody's going to understand you.
Yeah.
Um, and the forms that we have people fill out, the intake forms are quite inclusive. And we've gained a reputation for this as a place to go, to where you're going to be respected and hopefully not misgendered. And even then, it's not perfect. I mean, there are still people who work there who kind of, get a little bit lost with pronouns and things. While I was there, of course, it was, people were quite, excited that there was a non-binary trans doctor, a queer doctor, um, and you never want to be the only one because if you leave, then there
Yeah.
isn't that anymore. But I was, you know, from time to time there have been others, but um, and yeah, so that's basically like how what are the simple things you can do to just and unfortunately, I guess we've experienced this discrimination for so long that only it only takes the bar is really low. Like the little things that will make a person feel included are so minimal,
Yeah.
and I want to make it so that you're not just doing the bare minimum. Like you're actually going beyond that to actually what everybody else gets and what everybody deserves as far as like just really including everyone. And that was very, but um,
No, it was
at the end of the day, it affects people's health in a really real way, and it's measurable. And um, and then we talk about intersections with, in my case, it's Maori people mainly, and people Pacific Island immigrants are the main sort of minority ethnically, and when people intersect in those different identities or groups, they have even more disparities. We know that Māori people don't live as long. Māori people have worse health outcomes and all these things, and we also know that um, LGBTQ plus people have worse health outcomes for various reasons, depending on which letter you're in, um, and seek less care because they're afraid or don't get screened for things as appropriately and often as they should. And um, so,
yeah.
yeah.
I think you um tackled a few things in that last statement. I think one, thinking about as we present to wherever, but in the context of medicine, we present to a clinical office and being taken care of as a person, our person first, and not having not having to feel like you're put in one of those little check boxes, right? And so, and then
Mm,
even, and we talked a little bit before, like even if you list all the check boxes, sometimes you still don't fit in one of those. But being in a place that says, you don't have to fit in one of these check boxes. We're just trying to figure out how the best way to take care of you as the person that you are. And I think that's still, it's still a hard thing. I think the other point that you mentioned, which is slightly different, but I think very important, when you are the only one. And, I think as Black Americans, we feel that a lot, we're the place, we're the only, Black physician in the area. And if you, for whatever reason, life, career, your own personal illnesses take you away from that position and feel like you're leaving or abandoning these patients, and that's hard. That's a lot of
Mm,
weight for one person
mhm,
to deal with. um and but you feel it and you have to do something with that. And the best thing that we try to do is educate people around us to hope that they can take care of our patients as well as we hope we're taking care of them. I think the work that you're doing around advocacy on how to make things inviting. We talk a lot on this podcast and Reskiles in general, like how do we help to work towards the policy changes, kind of like to your what you're talking about in the national system when we're looking at IT changes, and you have these huge things that don't. I mean, I'm sure it takes a lot to like change these large EHR systems. I mean, I don't think it's a click of a button,
mm,
but there are steps and policies that can be put in place that can just the little things that make people feel more inclusive and invited. And to your last point, at the end of the day, we want people to come in and get care. And so what we don't
yeah.
want, and with the stories that you hear, is I went one time, I was uncomfortable and I don't ever want to go back. And that's not
Mhm,
how we want people to feel. We want you to, we know it's the process. With every relationship, we have to learn each other. Um, but come and let us learn you and let us take good care of you. And I don't, I think we don't want anybody going home feeling like that, feeling like they weren't seen or they weren't heard. Um, and not having the care that they need. So, any which way, that's my little ramble for that. Before I let you go, because we are running a little short on time, and uh, um, I don't want to keep you forever, but just thinking a little bit more about kind of as you want to envision your next step, as you think about your journey in non-clinical medicine, and as you're thinking about the new organization that you're working with and kind of the more advocacy lane. Um, any thoughts or I guess hopes around advocacy work for the LGBTQ plus community, or where you think you're going to continue to grow in that lane, as we're looking off to the future?
Yeah, well, I've been doing a lot of work on that in the last few months, I guess, of personal work, of like how that's going to look. I I feel like I'm a storyteller. Like I feel like one of my things is I can tell my story, and I love to write. So I've started doing some writing and publishing some of the articles on LinkedIn. I'm not really sure where else to post them, but places where people might be able to see what I'm interested in. I actually have formed a bit of a relationship with a group called the SDIG, the Systemic Diversity and Inclusion Group, which is um, basically it's kind of around that people bringing their experiences of diversity and inclusion and writing about them, and they have a you know forum for publishing those. And the director really likes my writing, so I mean none of these things are paid opportunities, obviously. So, and I'm still in a place where I have a 14-year-old stepdaughter and a 16-year-old child, and we have financial responsibilities and so forth. So I can't work for free just
Yeah.
yet,
The
even
kids
though
have to
that would
eat. The
be
kids have to eat.
the kids have to eat and need clothes and so forth. Um, but when I visualize myself, like I feel like I would be best both for me myself and my own health and my own well-being, and also what I could do to impact the world. I'd love to like sit in a room and write, think and write my
Mm,
thoughts. And with the internet, you can put your thoughts out there and have people read the stories, my experiences, my story, but also, my experiences with other people's stories and how that actually affects. I mean, I can write about statistics all day,
yeah.
this percentage of, you know, this percentage of lesbians die of cervical cancer because they don't get their smear, whatever the
Right.
things are, and but that doesn't really impact people, I don't think. I mean, I've found that my whole life, like the things that have impacted societal change regarding, same-sex marriage or transgender rights or whatever, is people telling their stories. So it's kind of broad, but that's kind of where I want to be. I want to be doing writing. I mean, I have applied to a variety of different jobs. I've gotten sort of nowhere with all of that, but um, I might have to put food on the table, do something that feels a little soul sucking, like doing writing for a pharmaceutical company for a while I can, you know. But I mean, I would even like to have, if I could have a job in, a company that has nothing to do with medicine. Like I
Mm,
applied for a diversity and inclusion specialist or manager or whatever at a tech company because
yeah.
I know that tech is a place where women and minorities are still highly underrepresented, and I think that's really important. And I think you need diverse people to champion the needs of diverse people, and people aren't going to apply for jobs at places where they don't see people like themselves. I mean, I saw that applying to residency. Like even when I was a female presenting person applying to residencies in the mid 90s, going to residencies where there were no women, or whatever, or they didn't have it. Yeah, they weren't obvious anyway.
Yeah.
They were hidden in the kitchen. I don't know.
It's
And yeah, so I guess that's a bit broad, but it's where I think the storytelling and the writing and the advocating for people, being the voice for people who need their voice heard but don't sort of have the somebody to kind of help them tell their story, I
yeah,
guess is kind of the
be the
place I
platform.
want to go with that.
Yeah, definitely. I mean, I think that is the other thing we talk a lot about in the health equity space. So, and one of the things I hope to your point that we get across in the podcast is that health equity conversations are not siloed to healthcare and clinical spaces, right? And we need to keep moving
Mm-hmm.
them to things that affect people's everyday life, like their employment, their education, their transportation, right? Um,
Mm-hmm.
Education, access to food, and that type of thing. And until we have people having these conversations in those spaces, then we're not really going to affect somebody's overall health outcomes. And so that is really what we're trying to get to. So no, that was a perfect conclusion on your part. I appreciate that.
Well,
So
thank
with
you.
that, I will thank you again for spending some time with us and being so open to share your story with us and your evolution in medicine and as a person and career wise. And so I think we got a lot from you in this short amount of time. And so I really do appreciate you sharing and being open to doing this podcast with me today. So thank you so much.
Thank you so much, Mary. And I really appreciate you inviting me on. I'm really honored
Yes.
to be part of this amazing group of people that you've had on your podcast.
Well, thank you. Now be careful because I might bring you back. So all right. Well, you have a good day.
You too. Thank you.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.